ladies and gentlemen. Good afternoon, ladies and welcome to the poster presentation of the SIMCOM 2021, the annual academic sessions of the Sri Lanka College of Internal Medicine. I am Dr. Ravi Dissanayaka, specialist in internal medicine. Today we have 16 presentations lined up for the posters presentations of SIMCOM 2021. First, let me introduce today's judges. Professor Panduka Karunanayaka, Professor in Medicine, University of Colombo. Welcome, sir. And Dr. M.K. Raghunathan, Senior Consultant Physician. Welcome, sir.
Thank you.
First of all, let me go through the procedure. So each presenter will be allowed 5 minutes for their oral presentation of the poster, followed by 2 minutes of question and answer time for the judges. So let me move to the first presentation for today, presented by Dr. I. Wettasinghe.
Good afternoon, ladies and gentlemen. My name is Dr. Indika Wettasinghe, and I'm here to talk about a study which is conducted among post-intern doctors to assess their knowledge and self-confidence regarding the diagnosis and management of anaphylaxis. So as we all know, anaphylaxis is a medical emergency, and early recognition and management is crucial in minimizing the morbidity and mortality. And these post-intern doctors have just completed their house officer period, where they were the first contact doctors primarily responsible for the diagnosis and management of anaphylaxis. So the specific objectives of this study was to assess their knowledge and self-confidence regarding anaphylaxis. So this was a cross-sectional study which included post-intern doctors who graduated from 3 Sri Lankan universities and finished internship in 2020. Consecutive sampling was done and data was collected using a self-administered questionnaire, which consisted of true-false questions, single answer questions, and open-ended questions. 285 doctors participated in this study with a response rate of 74%, and 64.6% of the population were females. So regarding the triggers of anaphylaxis, when we come to the results, 26.3% of the population identified all stated anaphylactic triggers. And knowledge regarding allergens such as green leaves, chickpeas, green grams was poor. And knowledge regarding allergens such as soy, sesame, wheat products was low. Only 7% of the population did not know that there was a set criteria to diagnose anaphylaxis. And 4.6% of the population did not know that anaphylaxis can occur without hypotension. And only 13.7% correctly diagnosed all 10 case scenarios, with the mean score for case diagnosis being 8.06. And here we found that the better the performance in the final MBBS, better the results in the case diagnosis. And there was a statistically significant relationship between this results category and the mean score for case diagnosis. And this was the only independent predictor. So gender, type of hospital and unit, doing medicine as an appointment, or even the number of anaphylaxis patients diagnosed during internship were not predictors. When we come to the management of anaphylaxis, 92.6% of the population correctly mentioned that the first drug to administer was 1 in 1,000 adrenaline. However, one would have expected 100% of the population to know this fact. 80.7% of the population stated the correct adult dose of adrenaline, and only 61.4% of the population, surprisingly, only 61.4% of the population knew the correct pediatric dose of adrenaline. So the other striking findings were that 25.3% of the population were under the wrong impression that the best site to administer adrenaline was the deltoid muscle. And 46.0% of the population did not know that follow-up care needs to be arranged for all those who have been managed for anaphylaxis. So the mean score for anaphylaxis management was 17.01. And once again, there's a statistically significant relationship between the final MBBS results category and the mean score for anaphylaxis management. And this was the only independent predictor. 91.9% of the population were confident in diagnosing anaphylaxis, and 80.4% of the population was confident in managing anaphylaxis. And here there was a positive correlation between the diagnosis score and the self-confidence in diagnosing anaphylaxis. So these are our conclusions, and we would like to recommend that more emphasis should be put on teaching anaphylaxis in the curriculum, both in the university as well as in hospital setting. As you could see, our study has found some areas where the knowledge was deficient, and these problems need to be addressed. So this concludes my presentation. Thank you.
May I ask you a question? I'm Dr. Raghunathan. Can you hear me? Can you hear me?
Yes, we can hear you, doctor.
Yeah. Okay. Now, what about? I don't know whether I missed in your presentation. Did you see about the more important part of it? This is, all these patients have not died or something. All these patients who have been treated by these young doctors. What about the future, in the sense how to prevent the future, like EpiPen, whether they can afford it, whether that's one of the important part of it. Did you look at that part of it? You got my question? In the sense, in future management of the patients, what are these people going to advise?
Yes, okay, yeah, no, we did not assess that fact, sir, as to what exactly they're going to do for the patients. It was more about the knowledge of the...
Yeah, but don't you think in the overall management of anaphylaxis, these people have seen one anaphylaxis, your candidates have gone through, you are checking their knowledge. But one of the important thing is, what are they going to do to these people who had anaphylaxis in future? How are they going to, because if they are going to wait till go to normal doctors and get hydrocortisone and this and that, then the knowledge, having any amount of knowledge is not good enough. Prevention, I don't know whether Panduga, what Panduga?
Yes, no, I think the presenter answered the question. Yeah. Do you want to add anything else, the Dr. Wettasinghe?
That's fine. That's fine.
Yeah.
Okay, that's fine. Thank you.
Okay.
Any more questions from the panel of judges, sir?
I'm okay, Ravi. We can carry on.
I'm okay as well.
Okay, shall we move to the next presenter then?
Yes,
Okay,
please.
Ravi.
Presentation number 2. Presented by Dr. Karunatilaka.
Hello everyone, I am Dr. Parakrama Karunatilaka. Let me present our abstract effect of diet and physical activity on the spectrum of acute coronary syndrome in South Asia. Acute coronary syndrome is the leading cause of death worldwide, and its incidence is even higher in South Asian countries. We did this study to evaluate the dietary pattern and physical activity among patients with acute coronary syndrome and to see their variation among the spectrum of acute coronary syndrome, which is unstable angina, non-ST elevation myocardial infarction, and ST elevation myocardial infarction. So we did this cross-sectional descriptive study in Teaching Hospital Peradeniya from November 2016 to March 2020. We used interview-administered structured p-validated questionnaire to collect data, including a standard foot frequency questionnaire, and the analysis was done using SPSS 26.0 statistical package. We recruited the total number of 789 patients with confirmed diagnosis of acute coronary syndrome into this study. The population had a mean age of 60.76 years, and it consisted of 59.6% males. The proportion of unstable angina, non-STEMI and STEMI in the population were 38.0%, 32.1%, and 29.9%. We calculate the mean hours of physical activity per week in the population. We considered 4 main categories of physical activity: vigorous, moderate, walking physical activity, and sitting physical activity. Regarding vigorous physical activity, STEMI and non-STEMI patients showed a higher number of hours of vigorous physical activity than unstable angina patients. Regarding moderate physical activity, STEMI patients showed a higher number of hours of moderate physical activity than non-STEMI patients. However, it did not show any significant difference with unstable angina. Regarding walking and sitting physical activity, it did not show any significant difference within the spectrum of acute coronary syndrome. Regarding the dietary patterns, we calculate the mean number of times the patients taking each dietary component per week. The majority were consumed rice included in cereals, mean value of 24 times per week, and next vegetables, mean value of 17 times per week. The intake of meat, eggs, salted foods, and nuts were less than once per week in this population for a mean value. Here the salted foods means salted snacks, dried potatoes like foods. The consumption of milk products was higher in unstable angina patients compared to the non-STEMI patients. And other food components did not show any significant difference between the spectrum of acute coronary syndrome. Importantly, the consumption of high fat content dietary components were less compared to the Western population in our study sample. Therefore, in conclusions, the dietary patterns of acute coronary syndrome patients in South Asia does not consist of unhealthy food habits like high fat content diet compared to the Western population, and engaging in vigorous physical activity negatively associated with the severity of acute coronary syndrome, where those who are engaging in vigorous physical activity are more likely to get non-ST elevation myocardial infarction or ST elevation myocardial infarction than unstable angina. And the hours of walking and sitting physical activity does not show any association with the spectrum of acute coronary syndrome. Thank you.
Thank you, Dr. Parakrama. Can I ask a few questions, Ravi? Shall I go ahead?
Yes, sir, go ahead.
Thank you. Yeah, Parakrama, I'm wondering what is the reason why you decided to look at the dietary and physical exercise patterns? Why did you assume that it would be different in the 3 categories of patients in acute coronary syndrome? Because as far as I know, they share the pathophysiology. So why did you think that the patients, what was the reasons? Are there any biological reasons why they might have been different?
Yes, sir. First, sir, in this study, we wanted to study the dietary and physical activity patterns of the patients with acute coronary syndrome, sir. So initially our analysis was to calculate the dietary patterns and the exercise patterns and compare them with the other populations in the world with other studies. However, while analyzing, we noticed some kind of variation in those dietary patterns and exercise patterns within the spectrum of acute coronary syndrome as well, sir. Because those who are engaged in vigorous physical activity are more likely to get STEMI and non-STEMI, like those things. Because of that, I thought of emphasizing that fact in this abstract, sir.
So why do you think that happened? I mean, is there a reason why it might have happened?
Pathophysiologically, sir, the pathophysiology of acute coronary syndrome,
Yes, you know.
the atherosclerosis is the same for the unstable angina as well as STEMI. So because when there's unstable atherosclerotic plaque, they are more prone to get STEMI. Still, within this study, we have not yet evaluated any the reason for those variations, but for the time being, we have that fact that there is some variation. However, the pathophysiology wise, in the literature review also, we couldn't find any exact reason for that. So,
Thank you.
Any more questions from the panel of judges, sir?
I'm fine. Thank you.
thank you very much, sir.
Thank you, Dr. Karunatilaka. And let's move to the next presentation, poster number 3, presented by Dr. Prasad.
Good morning. I am very happy to present my research on descriptive cross-sectional study on knowledge, awareness and adherence to medications among hypertensive patients in a tertiary care center of Eastern Sri Lanka. The hypertension is one of the most common non-communicable disease as well as the public health problem among developed and as well as developing countries. The lack of knowledge and awareness on hypertension and poor medication adherence are the major challenges to control hypertension and prevent its complications in our country as well as world. Our study aimed to assess the knowledge, awareness of hypertension and adherence to medications among hypertensive patients attending to medical clinics of tertiary care center of Eastern Sri Lanka. The study was carried out among hypertensive patients in a medical clinics in a tertiary care center of Eastern Sri Lanka for 6-month duration. The data were collected by using pre-tested and validated hypertension facts questionnaire. The medication adherence and reason for non-adherence were studied using modified medications adherence scale. The data were analyzed using SPSS analytical package and chi-square test was performed. The scoring system was used to categorize the level of knowledge and awareness of hypertension among hypertensive patients. In our results, we found that most of the patient has moderate to high knowledge, which is about 65.8% about hypertension, and had moderate to high awareness, around 73.2% on hypertension. However, 87.6% of patients knew that they have hypertension, and 70% of patients didn't know their blood pressure values at time of diagnosis. Most of the patients had good drug adherence, and most of them thought that taking medications plays a key role to control their blood pressure as well. The main reasons for non-adherence of medications were forgetfulness and expenses. The knowledge and awareness about hypertension among the respondents were significantly associated with educational status. Furthermore, in our study, we have concluded that most of the patient has adequate knowledge on their risk factors and complications of hypertension. However, they were unaware about their disease status and their diagnosis at time of diagnosis, and target organ damage and recent blood pressure values at clinic. Moreover, the main reasons for non-adherence of medications were forgetfulness and expenses as well. Thank you very much.
Dr. Prasad, can you hear me? Dr. Prasad? Hello?
Prasad, can you unmute your mic? Yes.
Can you
Thank
hear
you.
me, Prasad? Dr. Prasad?
Yes,
Yeah. I want to ask you two things about, did you try to find out in the awareness of these patients
Yes.
about there is no correlation between the symptoms and the blood pressure? Because very often the patient think they have blood pressure only when they are symptomatic. That's one. Number two, did you try to find out whether they know whether the blood pressure treatment has to be long, at least lifelong, or at least for a long time? It's not for that particular period where they have seen the doctor. Were these
Yes.
two questions did you try to find out from them?
Yes, regarding the symptoms, sir, they have a high blood pressure, sir, but they are most of the time asymptomatic. The patients has high blood pressure at the clinic visit, but they didn't have any symptoms, sir. Only has some giddiness, but that's not significant to cause any serious medical advice or admission. In the meantime, sir, regarding the meditation, sir, I have selected the patients. They have diagnosed hypertension more than 6 month duration, and they already on drug treatment for at least 6 months, continuous drug treatments. That kind of patients I have selected.
Dr. Prasad, if I can ask you a question.
Yes, sir.
What do you think is the drawback in your study? The biggest drawback in your study. What do you think is the biggest drawback in your study?
So because drawbacks, sir, most of the patients has high educational status about their hypertension. What is the hypertension? What is the cutoff value? What is that? But they, even though they have good knowledge, they did not bother about their own disease status. If they know the hypertension, they didn't know we have to control our hypertension. We have to go to the clinic. We have to take the drugs. They are most of the time they were unaware of what time the diagnosis was made, and what is the time of blood pressure values at the time of diagnosis. And in addition to that, they didn't know what is the target blood pressure. If they have blood pressure, they know.
If I can just stop you there a little.
Yes.
Sorry. What was your objective?
Yes, sir.
What was your objective?
To assess the knowledge, awareness, and meditation adherence to the hypertensive meditation among hypertensive patients.
So if you wanted to check the medication adherence, would there have been a better way to check the medication adherence than a questionnaire survey?
Yes, I have assessed the meditation adherence using the modified hypertension adherence scale, or which is already on pre-existed in the literature, sir. That is a Morsky adherence scale.
That is, in which language is the scale given?
Yeah, but problem is a Morsky scale, sir, because I have to use the scale using the permission from Morsky, sir. But I have conducted, but he didn't conduct. That's why I have modified the version of Morsky scale with my own words. After that, I have to create more scale, sir.
The scale was originally in what language?
What, sir?
In what language was the scale originally found?
Original, sir, English, sir. I have translated to Tamil.
Okay, so have you validated the Tamil translation?
Yes, I have validated the expert validation, sir, with my consultants and also 2 professors and 2 consultants and registrars and house officers and English teachers. Not a content validator, sir, not a expert validation.
Right. So do you think that a questionnaire can detect adherence? Do you think that a questionnaire can detect adherence reliably?
But I can understand, sir.
Can a questionnaire reliably detect adherence? You can't understand the question. Okay, fine. Thank you.
Thank you, Dr. Prasad.
Yes, sir.
We'll move to the next presentation if the judges are happy about the question time.
I'm okay.
I'm okay.
Thank you, sir. Shall we move to the presentation number 4, presented by Dr. MMPT Jayasekar. Over to you, Dr. Jayasekar.
My topic is knowledge, attitude and practices on COVID-19 among healthcare workers in selected hospitals in Sri Lanka. Lack of knowledge, inadequate practices and negative attitudes among healthcare workers can subsequently lead to themselves falling ill and putting others' lives at risk. Our main objective was to assess the knowledge, attitude and practices related to coronavirus disease among healthcare workers in selected hospitals in Sri Lanka. This descriptive cross-sectional study was conducted in 12 hospitals. If you see this Sri Lankan map, you can see from Jaffna to Tangor, there are hospitals all over the country. So this was done between June to September 2020, before the invention of a vaccine. Data was collected using self-administered questionnaire. The knowledge had 10, attitude 15, practices 15 questions respectively. Cut-off level more than 75% for the good knowledge, more than 87% for good practices, and mean score more than 46 is considered a positive attitude. Software statistics and data sciences version 40 was used to data analysis. The comparison was done using multivariable analysis. If you look at the results of a study population, there were 67% females with the 33% of males, and 52% of nurses and 48% of doctors. 64.9% had good knowledge, 50% had positive attitude, and more than 95% practiced preventive measures. And 84% disagreed on giving minimal care to COVID-19 patients. And 51.5% not for it to treat COVID-19 patients. Good knowledge of COVID-19 was associated with being a doctor. Good practices were associated with adequate knowledge, being married, and being a doctor. So in conclusion, although overall knowledge, attitude, and practices are satisfactory, it is important for healthcare workers to have excellent knowledge, 100% adherence to preventive measures, and maximum possible attitudes towards COVID-19 for the purpose of safeguarding themselves and mitigating the pandemic. Thank you.
Can I ask a question?
Yes, sir.
Yeah. So, what do you mean by practices? What were the practices that you tested?
So hand washing, distance maintaining, and when they're looking after the patients, mainly the using masks and like mainly the hand washing, distance maintaining. Once they look after the patient or take care of a patient, using PPE, those are the things we use, sir.
So basically, infection control practices.
Yes, infection control practices.
Okay, right. And you said so many a certain percentage disagreed on giving minimum care.
Yes.
What do you mean by that?
So there was a the attitude questionnaire. So there are about 15 attitude questions. So there's a one question asking, it's a Likert scale one, whether you are you agree on giving on lowest care to the COVID-19 patient. So some people agreed, some people not agreed, disagreed.
That must have been the Sinhala or Tamil, no?
So it is in English because this was done in the nurses and the doctors.
So
questionnaire was in English.
Okay. I couldn't understand the question. What exactly do you want to find out in that question?
So not only that particular. So I am agree to give minimum care to COVID-19 patient. That was the question. So the Likert scale, agree, disagree, partly agree, kind of. There were 5 things to answer.
So minimum care meaning I am agreeing to give minimum care, but I disagree to give more than minimum care or something like that.
That is one of the questions. The other questions like I am happy to monitor blood pressure of a COVID-19 patient. Agreed, not like that. The Likert, there were question. This is one of the questions. The overall care at the end of the question. This was the overall care given to a COVID-19 patient. So most of them disagreed to give minimum care.
Meaning, what do you mean by that statement that they disagree to give minimum care? What did you mean as the person asking the question?
That means they are happy to treat the patient. Vice versa.
Thank you.
Thank you, sir.
Any more questions from the panel?
I'm fine.
Thank you, sir.
I'm fine.
Then thank you, Dr. Jayasekara. Shall we move to the next presenter?
Thank you, sir.